Good morning. Thank you, Ian.
We'll get your presentation up one moment.
Yeah, I was about to ask for it. Okay, thank you. Yeah, I work for SMS in Ethiopia, and I am also the PTD liaison for Ethiopia. I have been for PTD liaison for 3 years now. I'll be talking about our work, SMS work in Ethiopia, and which has helped the government in achieving lots of great results. And whatever reported here is not only SMS results, it's a collaborative work with the government, our prime partner, and other government institutions, and of course, other stakeholders. And I'll be talking about where we were in 2006, just before we start working in Ethiopia, and what we did throughout these years, and where we are now. And with special emphasis on, of course, on our HR capacity development activities. And I'll be discussing that in line with the 5 building blocks that Erin just discussed. This is just to give you a context. Those of you who were here yesterday have heard Atoyamana from PFSA talk a lot about their organization and supply chain structure in Ethiopia. So in Ethiopia, SMS started working in 2006, and as you know, it's the largest single nation commitment for a specific disease. And the mission is, of course, to avail HIV/AIDS commodities through building the supply chain structure system. And Pharmaceutical Fund and Supply Agency, Pharmaceuticals Fund and Supply Agency, in short, PFSA, is the government institution which is responsible for procurement, storage, distribution, and management of all health commodities in the country. And there are 9 regions and 2 city administrations in the country, and they have got health bureaus, regional health bureaus, which are responsible for the service provision at service delivery points. So PFSA and the regional health bureaus are our prime partners. So where were we in 2006? This is statistics from government documents. And from 2003 to 2006, the prevalence of HIV was significantly decreasing. And over 1 million people were living with HIV/AIDS by then, but only 25,000 people were on treatment. And there were only 50 treatment sites, barely 50 treatment sites, and there was no LMIS, be it paper-based or electronic. And PFSA had very limited capacity. They were operating only from 6 warehouses, and all their trucks were very old and very limited in number. And some studies indicated that there was serious and significant shortage of essential medicines in most of the health service provision centers. And of course, supply chain knowledge and skill was limited. So what we did, SMS did, is first we are fighting fire, of course. So we're trying to respond to the crisis, to the HIV crisis, and we're trying to put as many people as possible on treatment. But then after around 2008, we developed a joint work plan with PFSA, and we called it the Quick Win Plan. And that plan was based on the principle of build, operate, and transfer. And later in 2011, we added optimize, because once we had the infrastructure, the system, and the people there, we really wanted to improve efficiency. So we added optimization as well. We'll be discussing what we did very soon. So by then, the supply chain related challenges, personnel related challenges are listed here. They are not limited to these points, but this summarizes most of the problems we used to have. There was no proper recognition of HR for SSM, and there was no champion for HR for SSM. And the same experts requirements were not clearly defined. And the supply chain management courses being provided to students at undergraduate level or in-service level, all these trainings were not standardized, and they were not adequate in terms of content and length and everything. And the retention mechanism for staff in the public sector is and has always been very weak. So these were the trainings that we want to address. But the last point, the Ministry of Health drafted HR for health strategy, but then supply chain was not considered at all. We also noted that as an issue. So we tried, now what I'm going to discuss is what we did in terms of these 5 building blocks. Of course, we helped the government develop policies, strategies, procedures by engaging them, of course, in the process. and by working with them, not for them. And we tried to provide relevant training to supply chain experts, and we supported them through support supervision to improve their performance. And for sustainability, we are also working on professionalization of SAM through institutionalization of trainings. So, engaging stakeholders, let's look at this quickly, and we will mention specific examples at the bottom of the slide for each building block. For this point, for instance, we've been working with PFSA and RHB again, and we identified common HR for SCM related challenges, and we developed interventions together. By doing so, we managed to create ownership for all the and responsibility for all the actions that we take. And SMA seconded experts into PFSA warehouse, and they were helping to train PFSA staff in their warehouse. And while operating the systems, they were also mentoring and coaching PFSA staff. And finally, what the intention is and what we are working towards now as the project is phasing out is to transfer skill and knowledge for sustainability. With regards to optimizing policies and plans, we had very good examples. In the eastern part of the country, for instance, we worked with the regional health bureau to develop a job description. And previously, supply chain experts have some sort of job description, but it does not have logistics as specific responsibility. And especially when PFSA introduced the integrated pharmaceutical logistics system, which has a paper-based and electronic LMI system entailed in it, these people, they don't have it in their JD, so they are not being accountable. But the development of this, the revision of the job description helped them to take part. And developing the workforce, of course, we've been providing support supervision to as many as thousands of facilities, and we've trained 6,000 plus people on different supply chain management courses. Some of them are international courses like warehouse operations management, which we collaborate with IHS in South Africa, which is part of a supply chain management system, of course. And we've been providing specific trainings on integrated pharmaceutical logistics system, which focuses more on paper-based LMIs, but also warehouse improvement at facility level. Supply chain management and monitoring and evaluation trainings have also been provided. And we even provided training to drivers and forklift operators for optimum utilization of equipment, expensive equipment that donors and government spend a lot of money on. So we're talking about on HR, but PFSA has grown significantly in terms of infrastructure too. They have built a number of warehouses, a modern warehouse equipped properly with racks, which has never been the case in the previous years. To complement that, the people we're sending to South Africa will be trained and have been trained on modern warehouse operations management practices. And increasing performance. For the first time, we tried to introduce key performance indicators into the warehouse operations, for instance. And people trained on warm warehouse operations management are expected to develop a plan of action for implementation with timeline, responsibilities, and resources attached to it, and that helps to improve their performance. And supply chain management monitoring and evaluation course, which is a standard course, has been tailored to the Ethiopian context, and we use that to provide training to government institution staff, and they are developing monitoring and evaluation plan for the first time. This will help them to monitor their performance and take appropriate actions as required. When it comes to professionalization of supply chain management, we've been talking about it since the first PTD conference, but as Erin said, not all of us made significant progress towards it. But what we tried to do is we went beyond PFSA, our prime partner, and tried to discuss this with Ministry of Education and its higher teaching institutions. And we developed curricula for supply chain management courses. We're trying to get it approved by Federal Ministry of Health. And the Ministry of Health, in fact, has a new directive for in-service trainings, which said that people and partners have to move from hotel-based training to institution-based trainings. So we've started this prior to this directive, but we'll try to pursue that and finalize it. Lessons learned. The first thing we learned from this exercise, from the work over the past few years, is that participation is key for success. In fact, for instance, by involving the staff who are affected or will be affected by the job description revision, we have a chance of, we maximize the chance of accepting it when it's implemented by the same staff. So in our example, for instance, in Day2, we involved the staff themselves in the job description development, the regional health bureau people, people from the civil service bureau, and all those relevant people, and that helped us to implement it so easily without no significant challenge. And of course, participation also helps to create common understanding of the situations and clarify expectations. At regional level, for instance, we also have technical working groups in all the 11 regions, 9 regions and 2 city administrations. And that's a forum that we use to identify supply chain related HR issues and plan accordingly, but together. And communication is also another key factor if you are going to achieve excellence in the SMHR area. In our case, we've been involving federal institutions like the Federal Ministry of Health and PFSA, and recently the Federal Ministry of Health took the initiative to organize a technical working group to discuss HR-related issues for SM. This is the first time, by the way, in the Ethiopian history. And we shared the global experience, what is out there, what has been done in other countries, what has been tried and what has been successful, what's not working and why. And we took all the documents that PTD developed through the years, and we presented that. And some of your country experiences are also discussed. So that gives them some sense of the situation. We also communicate with the regional, zonal, and district level, which are the lower levels in the administration. And we engage them so they will not be surprised when we plan to do something. But finally, the most important thing is training by itself is not the end, or developing a job description is not the end, or having the right policy is not the end. All HRCD related activities and plans should consider the whole picture in general. So trying to address all the 5 building blocks in the process is very important. Institutionalization for sustainability, this is another important thing. Projects phase out, but the system and the governments continue to exist. And they should be able to take this on and continue the good work, especially when it comes to training. You know, in the video earlier, we saw that the health worker left and everything falls apart. To avoid that situation, we should be able to have a sustainable training strategy. And by doing so, we are considering these facts, we've been trying to nationalize some of the trainings into public sector, higher level teaching institutions. So where are we now? Again, this does not mean that what we did in HR for SM resulted in all this, but it helped, it contributed to these achievements. Currently, PFS is operating from 11 regional warehouses out of, from 6 in 2006. And they're planning to grow into 17, which is in work, and we plan to reach 17 before the end of this calendar year. And it has now 150 modern delivery trucks. And more than 30,000 pallet space are created through vertical racking, which has never been the case previously. And modern material handling equipment are provided, introduced. LMIS, paper-based LMIS has been working efficiently over the years. Again, this in collaboration with other partners as well. And 2,000 health facilities have been reporting, plus 2,000 plus facilities have been reporting consistently with 90% or more reporting rate. And as Atuyamana has been saying yesterday, direct delivery, PFSA started direct delivery of products to more than 1,100 ART sites. This is like reaching each facility every 2 months. And they are planning to cover all the health facilities this way. More than 90% of essential drugs are available according to a very recent study conducted by USAID Deliver. PFSA distribution capacity has increased by 520%, with an annual turnover of more than $600 million. And in fact, their procurement capacity has also increased by 650%. Adult prevalence rate is 1.5% now, which came down from 3.2 in 2006. And out of 800,000 patients who are living with HIV, it's 350,000 plus people are on treatment. We are almost reaching complete coverage. The total number of people who are expected to be on treatment, considering the new WHO guideline, is slightly more than 500,000. So, and we have more than 1,050 treatment sites, ART treatment sites, which is from 50 or barely 50 in 2006. And the most interesting news is that there has never been any case where treatment interruption occurred. And with this, I thank you.